Okay, so let's look at a few routine projections that you may encounter when performing a shoulder examination. The first one that we're going to look at today is the AP with external rotation. This is a very similar position to the AP humerus. You want to externally rotate the hand so the palm is supinated. You will want to collimate to include the shoulder joint and the sternoclavicular joint for most of the radiologist's preferences. Here, you want to ensure that the internal part of your light field is covering the area near the jugular notch and the exterior or outer portion just the edge of your soft tissue. Make sure you properly place your marker in an area that won't obscure the anatomy. Let's look at the image that will be produced. Here, with external rotation, we have included the sternoclavicular joint and the entire shoulder joint itself. External rotation will place the greater tubercle into profile. We'll look at this and compare it to the internal rotation in just a moment. Now, let's look at the AP with internal rotation. Once again, we have very similar part position as we did with the lateral humerus, but focusing on the shoulder, once again, we want to include the entire shoulder joint and the sternoclavicular joint. Let's look at the image produced here. Now, notice we have included the sternoclavicular joint and the entire shoulder joint itself. As we look at the proximal end of the humerus, we can notice the difference between the external and internal. The greater tubercle is no longer in profile. And sometimes we may look at the humerus and say it has somewhat of a snow cone look. Let's go over here and compare it to the external rotation that does not have that. We can see both the greater and the lesser tubercle here, but the greater tubercle is in profile. Now let's move on to the lateral. There are two ways of performing the lateral. One can be PA and the other could be AP. Let's look at the PA first. Here, for a right shoulder, we have the patient placed in an RAO position. The right shoulder is closest to the IR. We have turned the patient approximately 45 to 60 degrees depending on their body habitus to get them in a good true lateral position. Notice how the humerus drops down along the longitudinal axis of the body. It's not brought back and it's not pulled forward. This will ensure that the scapula maintains that good Y positioning that we're looking for. And let's take a look at the image produced with a PA shoulder. Here we have a very nice Y defined by the coracoid and the acromion process, and notice that we have included the entire scapula all the way down to the inferior border. Also, you can see how that humerus goes right in line with the main body of the scapula. Now let's look how this can be produced in an AP position. For this particular position, we have chosen to lay the patient on the table. We've utilized a 45-degree wedge and placed it so the entire longitudinal axis of the body has also been at that same 45-degree plane. Let's take a look at the image produced. Here, we have very similar production that we had with the PA. We have the acromion and coracoid processes. We also have the entire body all the way down to the inferior angle of the scapula. And once again, the humerus is almost in plane with the body of the scapula. This is the kind of separation that we want in between the ribs and the body of the scapula. Okay, let's look at a couple axillary projections that we can do. Here, we have the inferior-superior projection. When coming at an inferior approach, it's best to lay the patient flat on the table. You'll want to abduct the arm as far from the midline as possible. Typically, getting 15 to 30 degrees of abduction away from the midline is usually acceptable. The more range a patient can get, typically the better you can get axillary joint space on your image. So as we look at this, there's a couple things to note. The central ray is perpendicular to the IR. The central ray should enter right through the mid-axillary region. We want to ensure that we have tight collimation and good marker placement. Let's take a look at the image here. When looking at your image produced, you want to ensure that you have the entire shoulder joint. The coracoid process and the acromion will be easily visualized as well. Now, let's look at the superior approach. Once again, a somewhat difficult position for the patient to get into. You'll want to seat them near the edge or end of the table. You'll want to have them place the arm over the IR. When doing so, have them tilt their head as far away from the light field as possible. Sometimes you may be required to change your angulation of the central ray depending on how well the patient can position for this. In this particular one, we were able to use a perpendicular central ray. Sometimes you may have to angle 5, 10, or maybe even 15 degrees. Just ensure that your light field is always displaying on the cassette and not throwing the shoulder joint off of the edge of the cassette. Let's take a look at the image produced here. Once again, very similar to the inferior approach, we should be able to visualize the coracoid, acromion, and entire shoulder joint, as seen here. Now, let's take a look at one final shoulder projection that we may encounter, the Grashey. Here, we have positioned the patient for the Grashey projection. The Grashey is a common orthopedic projection to look and visualize the joint space in between the humeral head and the scapula. For this, you will want to place the central ray to enter through the glenohumeral joint. For this projection, notice the tight collimation. This is typical due to the fact that this is usually an additional projection to a shoulder series. To get the patient in the proper position, you may need to rotate the person, RPO or LPO, 35 to 45 degrees towards the IR. And notice, for this particular Grashey, the patient's hand has been rotated in external rotation. Let's now take a quick look at the image produced with the Grashey. Here, we see the entire joint space as desired. We can tell that this is in external rotation because the greater tubercle is also in profile. The acromion is also included within this film. You now know the most common projections for a shoulder series.